Yes.
Okay, perfect. All right, I'm Ronnie Rivera, fourth year. This is my EMCCM lecture on a 30-year-old male with numbness for our EMCCM conference June 3rd, 2020. I'd like to thank Drs. Hansen, Unifying, and Barons, and Dr. D'Souza and Dr. Kim for their insane amount of effort that they put into this lecture together. So now I'd like you to sit back and relax, but please pay attention because it's a really complicated case and I have way too many slides to go through, so I don't know if we're going to make it to the end, but I want you to move fast and attempt to do it. So for people at home, I just learned recently that if you're muted, you can hit the space bar and hold it down and it'll allow you to talk quickly without having to unmute yourself. So, what? Well, you just hit this, you hold the space bar down, you can talk, and that'll let you make comments quickly without having to unmute yourself and take away some of the pauses and asking for help from the environment, from the home. Okay, so once upon a time in a land not so far away, you're working in the CCT, and the ambulance triage nurse comes running in a panic, screaming, "Doc, it's a twister, it's a twister." And you say, "What?" And she says, "It's a stroke code, rule out stroke patient, please." So, you speak to EMS and you get the following history. 30-year-old male with left-sided tingling sensation and dysarthria since 1:30 a.m. Went to sleep at midnight in his normal state. Vital signs are totally normal, but they noticed that he had a dysarthric speech and otherwise normal exam. They put him on 15 liters of oxygen because that's what EMS does for everybody, and they transferred him to the nearest stroke center. Your initial assessment is as follows. Basically, your ABCs are intact, and you find that they have a GCS at 15. Looks like there's some sort of left conjugate gaze pulse, and the patient handles are 3 up. Okay. So, your initial HPI of the patient. The chief complaint was numbness. He had wake-up symptoms starting at 1:30 a.m., but he went to bed at midnight, so the last known well time is midnight. He has either, depending on whether you're going by his wake-up symptoms or by his last known well time, 1 to 2.5 hours of symptoms. You note that he has difficulty speaking clearly, left-sided numbness of the face, hands, and arms, but he also noted that he's been coughing and have for about 3 to 4 days having fevers, temperature max home of 101.6. He denied to us that he uses any substance or had any previous trauma. So, Junior, preliminary problems. What do you got for me?
Fever.
Fever, okay. That's your priority, is the fever.
That's not my priority. Okay. Dysarthria.
Dysarthria, good. What else?
Numbness. Good,
numbness. Perfect. Dysarthria, unilateral numbness. Good. So, what do you want to do right now?
Head CT, non-contrast.
Head CT, non-contrast. What else?
Stroke labs.
Okay, great. And if you're going to do stroke labs and a head CT, who else do you want there with you? Neuro. So you're going to do what?
Stroke code.
Stroke code. Excellent. Very good. So stroke code, CT head, maybe even a CT head and neck, because this patient has left-sided numbness with the dysarthria. You could be considering a large vessel occlusion. Good. So this is the history from our primary team. No previous medical history, no medications, no allergies. The social history was really non-contributable. Vital signs are completely normal at 224. In general, well-nourished, well-developed, possibly overweight by his height and weight. He's had a neck exam. You notice everything is normal except for some strabismus, as was documented in the note, which I think likely refers to this lateral phase palsy. Chest cardio. They talked about the pulmonary effort being normal and the pulses being attacked, but there is no comment on the rate or rhythm of the heart from this exam. The abdomen, fine, normal. Extremities, normal. Neuromuscular exam. So they say he's alert, GCS at 15, has dysarthria, follows vocal commands, can lift all extremities against gravity, and the gait was superb. Likely because he was whisked off to CT scan before we finished our exam or before we did a bullet. So what's your differential diagnosis at this point? I think it was 125 was the fingerstick, yeah. Differential? Junior. There's not a junior. Junior's at home? Okay. Senior?
Stroke, MS.
Perfect. Stroke, MS, what else?
Spencer's here.
Spencer. Wait, say again? Good. So, intracranial hemorrhage, stroke. Other things that we shouldn't forget about are things like seizures with Todd's paralysis after a seizure. He woke up from sleep. COVID syndrome, we got cough and fever.
He was febrile, right? Yeah.
Yeah, cough and fever. So some sort of weird COVID encephalitis syndrome, who knows? Seniors, give me something more in-depth, something more detail-oriented that you might be looking for in addition. And a young, healthy guy who's coming in with stroke symptoms. Dissection. Dissection, okay. Anything else? All right, some things I thought of: hypoglycemia, Dr. Silverberg got to real quick with sugar. Hypokalemia from like periodic paralysis from hyperthyroidism can cause sort of a hemiparesis dysarthria. Intoxication, though he denied, it could cause some of these symptoms, or some sort of head and neck tumor could be causing some of these symptoms. Okay, so when he got back from CT scan, his vitals were still weird. I think this O2 is 91%, which is a weird documented one, because everything else was fine after that. Then electrocardiogram. This is where we got into one problem. There is no description in the ED chart, there's no description in the ICU chart, and no description in the neuro chart for what the EKG looked like. We don't have an EKG scanned into Epic or uploaded to Epic for the time that he was in the emergency room. There was an order placed around 6 in the morning, but then it was canceled at 6:32, likely because someone said it was already done when the patient came in. We've been having problems with getting them to upload, so maybe that's what happened. Results. You said stroke labs. Nothing really significant on the venous blood gas, maybe a little bit of low oxygen status and a lactate of 3.4. What? Then the stroke panel continued. Really nothing out of the ordinary. Potassium's a little low, ALT is a little high, monocytes were elevated on the CBC, but I'm not sure what to make of that. Imaging. Let's see if I can fix this for you too. So, as you're looking through, pay attention in these areas. Right there. See anything there?
Too much light.
Too much light? Okay, we'll do one more time.
Show the light.
That one over there. Right there, right?
One more time.
One more time. Okay, let me go one more time.
Oh.
Ooh, good, right?
Oh, now I see what you're talking about.
Okay, so ready? Right there. What was that little dot in the middle of it? Okay. Anyway, we'll continue. So what you're seeing is what we call a hyperdense basilar artery sign, and it's very common in about 50 to 70% of patients who come in with a basilar artery thrombosis. Okay. So the impression on the scan from the CT scan from the RAS resident was no intracranial evidence seen, but there's a distal third basilar artery tip hyperdensity consistent with thrombus. Okay, just a quick reminder of neuroanatomy. The basilar artery runs in the anterior rostral portion of the brainstem, gives rise to the anterior inferior cerebellar artery, the pontine arteries, the superior cerebellar artery, and the posterior cerebellar artery. It's commonly referred to as the posterior circulation because it supplies most of the posterior cerebral structures. So now what's our updated problem list? Right, stroke, but more specifically, the patient has a basilar artery occlusion. Okay, causing stroke. So basilar artery occlusion is seen in 15 to 20% of all strokes. 15 to 20% of all strokes occur in the posterior circulation, and the basilar artery occlusion accounts for about 1 to 4% of all strokes. Symptoms include things like truncal ataxia, nystagmus, extraocular motion deficits, and nystagmus, hearing loss. Patients can also have prodromal symptoms like vertigo, nausea, and headache with neck pain. Interestingly, you can get some weird things as well, like patients can get cross symptoms, meaning like they have a right-sided facial weakness but left-sided upper extremity weakness. And you can also get weird posturing, like twitching or twitchy movements that often are mistaken for seizures. Another thing that you have to be careful with this is patients can get locked-in syndrome from posterior strokes, which is a terrible outcome. Okay. There's also this really cool thing called Herald hemiparesis, which is like a transient localized hemiparesis that could come on before the stroke actually happens. It's like a preceding symptom of the stroke. What exam techniques do we use as physicians to evaluate posterior strokes?
Finger to nose gate.
Okay. What's the one that we're really terrible at?
Measuring gait.
That's it. No. There's one specific one that we recently had a discussion about how terrible we were at doing it, and the neurologists are much better. HEENT, yes, thank you, HEENT exam. So HEENT exam is one of the best ways to one of the ways to test for this if you're a interventionalist or neuroradiologist. Another thing that I found in the literature is that you can generally apply, they took a retrospective look at charts and they applied the ABCD2 score to patients who were presenting with symptoms of posterior stroke, and they were able to see that an ABCD2 score of less than 3 had like a 1% incidence. From 4 to 5, they had a 6.8% incidence, and from 6 to 7, they had a 27% incidence of posterior stroke. All right, so what do you think neurology said? Okay, so they said on their exam they found a left gaze deviation, flattening of the nasolabial folds on the left, 4 rapid alternating movements, finger tapping on the left, and significant truncal ataxia consistent with a posterior stroke. So pay attention to 2 things on this slide. Look at the time that the TPA was given from the last known well time, which looks like it was, where are we, 318, and the time between the NIH stroke scale of 6 and 4, 318 and 328. So in the ED, we gave the patient TPA. His stroke scale dropped to 4, then he dropped to 2, then we admitted him to the NICU for post-TPA observation. The neuro-resident also called neurointerventional radiology, and they decided against doing endovascular therapy for the clot because his stroke scale improved to 2 within the time that he was in the emergency room. So they thought the benefit and risk were outweighed by doing it, and they decided not to do that. As part of his admission workup, there was concern for COVID. So around 6 o'clock in the morning, COVID swab was ordered, a D-dimer was ordered, LDH was ordered for Cal. The dimer was significantly elevated, and the patient was transferred to NICU under suspicion for a PUI for COVID. All right, and by the time he was transferred to NICU, neurology noted his stroke scale was 1. This is his chest X-ray. Anyone want to take a quick interpretation? Normal. So no COVID features on his chest X-ray. Good. Okay. So as we left the ER, we have a 30-year-old male with dysarthria, paresthesia, found to have a basilar artery occlusion, received TPA. His NIH stroke scale dropped from 6 to 2, and he was admitted to the NICU for further monitoring. In the ICU, around 9 o'clock, the morning team was interviewing him and found that he had this episode of pre-syncope associated with some chest pain a week earlier. We did have in our note that he had pre-syncope, but we didn't get the chest pain history in our note. So they sent a troponin around 9:30, and it resulted at 9:47, saying that it was elevated at 1.33.
Is it downstate or county?
This is a county, it's troponin T.
Okay, it's pretty high.
Yeah. Yes, we admitted patient on troponin. So they did an EKG at 12:27 in the NICU, and this is what they saw in the EKG.
Oh, shit.
Can I get a senior to interpret this EKG for me?
I think someone said, oh shit.
I like that. It's no shit. All right. What do you see in B2, B3?
ST elevations.
ST elevations. Does it remind you of anything? Any particular type of morphology?
Tombstoning, possibly Wellens.
Possibly Wellens. Okay, good. I like that. So tombstone, possibly STEMI, possibly Wellens. Do you see any reciprocal changes?
No.
Okay. So what you see is probably persistent ST elevation from a myocardial infarction. A lot of patients, following a STEMI, the ST segments will start to return to baseline over like a 2-week period, and then the Q waves persist, and the T waves become flattened and possibly inverted. But you already see Q waves in B1, B2, and some in B3. You can get some degree of ST elevation in 60% of patients with an anterior STEMI and 5% of patients with an inferior STEMI. The mechanism is thought to be related to incomplete reperfusion of the transmural scar that develops. This EKG pattern is associated with the paradoxical movement of the chest wall. Sometimes can be associated with ventricular aneurysm. So it's a feature if you are trying to differentiate between something like this and a STEMI, you should look for reciprocal changes because that's how you're going to be able to tell the difference between either these persistent ST changes, ventricular aneurysm, and actual acute STEMI. Okay? So they read the EKG at anterior STEMI, and the cardiology resident did a bedside echo. They found that he had anteroseptal hypokinesis, an EF of 25 to 30%, mild left atrial dilations, and elevated pressures. So at 1 o'clock, he had a drop in his systolic blood pressure to 90/65, and they started a norepinephrine drip because they were concerned that he was having worsening heart failure. And then the cardiology consult suggested that they start a heparin drip for concern about the STEMI, but with the decreasing blood pressure, they were worried that they wouldn't be able to treat him should he start to go into cardiogenic shock. So they recommended transfer for possible PCI or intraarterial balloon pumps or ECMO or LVAD or something to keep him alive should he continue to drop his pressures. So, my case today, what do you think, what do you call this diagnosis? So, basically, it's a cardiocerebral infarction. I know you're all looking at me like this right now, like what the hell are you talking about cardiocerebral infarction? This can't really be a thing. But I'm going to ask you to put on your brand new set of Allbirds, and we're going to take a magical journey through the land of EMCCM. Okay? All right. So my discussion for today is, what is a cardiocerebral infarction, and why do we care? How do we get to current recommendations for treating acute ischemic stroke with TPA? And what should we and shouldn't we do for acute cardiocerebral infarction? All right. So first reported by Omar et al. In 2010, they coined the phrase cardiocerebral infarction. It has an incidence estimated at 0.009% of cases. But in the literature, patients presenting with strokes have been found to have a myocardial infarction reported as low as 1% and as high as 12%. STEMI patients have a risk of acute ischemic stroke of 0.9%. Stroke was often the highest 5 days after an acute myocardial infarction. And STEMI consistently shows little correlation with this cardiocerebral infarction. So having one arguably increases your risk for the other, and literature shows that after having a TIA, the relative risk for an acute myocardial infarction is 2.09 over the next 30 days. So it's almost double your risk of having a heart attack after having a stroke, a TIA. So there are two types of acute cardiocerebral infarction. The first one is synchronous, which is caused by conditions that give you a concurrent cerebral infarction and coronary infarction. So things like atrial fibrillation can cause this, where you get a simultaneous embolization of a clot to the coronary artery and to the brain. Or things like aortic dissection, where you're dissecting into the branching arteries and you get something like a dissection to the coronary arteries into some of the branching arteries with carotid arteries.
Just when a clot breaks off, it usually shatters. It doesn't go to just one place. It goes to like many different places.
Right, we see these embolic strokes where we see multiple embolic foci in the brain as well. Good, thank you. So the second type is metachronous, where one happens before the other, or one is the proximal cause of the other. You can have the heart first, the brain first, vice versa. One of the things that can cause this is anything that causes dysregulation of the brain-heart axis that causes myocardial infarction. So this can be something like a stroke in the insular cortex of the brain. Other things that can cause this are cardiac diseases that lead to cerebral infarction. So atrial fibrillation or heart failure with reduced ejection fraction. Going to this insular cortex, I thought this was actually really interesting. So when you look at your brain, the insular cortex is right underneath the outer cortex. They're closer towards the central portion of the brain. Infarct here can actually cause a myocardial infarction due to its role in the central nervous system and autonomic regulation. It has been associated with arrhythmias, disruption of diurnal blood pressure variation, and cardiac sympathetic overactivity. It gets its neural connections from the ventral posterior-medial nucleus of the thalamus, which is thought to manage our body's homeostasis. So an infarct in the right insular cortex is where the sympathetic control happens. You get parasympathetic overactivity. An infarct on the left, you get where the parasympathetic control is, you get sympathetic overactivity. So things to keep in mind when you're taking a dispo for your patient. You may also be wondering, why does a 30-year-old have a stroke? So here are some conditions. Basilar artery specifically, you can have embolic, traumatic vertebral artery dissection, aneurysms. Neurosyphilis was one I thought was interesting. And in general, it could be some sort of congenital thing. It could be a coagulopathy. Other things like carotid dissection, sickle cell disease are important in our population. So you may be asking yourself, okay, I've got all this information about this terrible, crazy, scary thing. How do I actually treat a cardiocerebral infarction? So I'm going to ask, we'll join up with some of our friends, and we're going to see who can help us on our way. But before we get started, I just want to bring back to the American College of Cardiology and American Heart Association evidence classifications. Just remember these as we're going through some of the literature, and so we can assess the quality of the recommendations. So our first friend knows a lot about hearts. We know that the pathology of a myocardial infarction can come from a few things, but the most common is plaque rupture, where you get a thrombus after a plaque rupture. And the other way you can get it is embolization to the coronary arteries from some other source. Right now, the standard of care that we accept is PCI within a certain window for certain patients. There were several trials that, like Cadillac and PAMI, who looked at the safety and efficacy of it. But how did we get here? There were trials like Gusto and Ascent that showed TPA stands out as an effective treatment for myocardial infarction. The dose was 15 milligrams as an IV bolus, then 50 milligrams over 35 minutes, and then 35 milligrams over 60 minutes. But it has to be given within 12 hours of onset. So we're seeing that maybe TPA can be given for heart attack as well. But if we go back to medical school, we start to talk about some of the complications of myocardial infarction. Within the first day, you get coagulant necrosis, reperfusion injury. The risk complications are ventricular arrhythmias, heart failure, and cardiogenic shock. In the 1 to 3 day period, you can actually have post-infarction fibrinous pericarditis. And it's estimated that about 7 to 25% of patients actually get pericarditis after infarction. And that pericarditis can actually become hemorrhagic.
First aid?
But
First aid?
maybe. Left ventricular thrombus actually happens in 2 to 8% of the population, and it's very common in anterior strokes. You can also have free wall rupture by lysis of the fibrin clot that happens within 3 to 14 days, and this can actually be exacerbated by giving TPA. And then 2 to 3 months, you can get things like Dressler syndrome, arrhythmia, and ventricular aneurysm. All right. So, in looking at the evidence for TPA for acute myocardial infarction, the current AHA recommendations say that it's reasonable based on Class 2B recommendations, considering the time and the type and location of the myocardial infarction. On average, studies showed that about 45% of patients had recanalization of a thrombosed vessel using TPA, but that 90% of those patients had recanalization when we use PCI instead. So we can see that PCI is better for reducing the complications as well. Studies have shown that patients who get PCI, we've actually seen a decrease in these post-myocardial infarction complications because of early interventions with PCI that have prevented them from happening. So you can see why they would say that it's really like a last intervention that you would use only if PCI isn't available, or if you're having a delay to PCI. Okay, so now we'll talk to our friend who knows a little bit more about brain. Currently, we consider treating acute ischemic stroke with TPA that falls between a 3 to 4.5 hour window, and if patients meet certain criteria. But my question is, how did every stroke code turn into TPA, 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 TPA? So, remembering the dosing regimen for TPA for acute ischemic stroke, it's 0.09 milligrams per kilogram given over 1 hour, but you give 10% of it as an initial bolus dose. Just like with acute myocardial infarction, there's a really solid body of evidence that endovascular recanalization is more efficacious. It's efficacious as well for treating acute ischemic stroke. It can be done within a 12 to 24 hour window, and it's specifically for a subset of patients. At UHB and Kings County, we consider it within a 24-hour window as well, depending on the perfusion studies that we do, usually like a stat MRI. But how did we get to this point where we started talking about using TPA for all these patients? So the first trial I look at, which is one of the pivotal trials for TPA, is the NINDS 1 trial, which was a comparison of a TPA versus placebo. And the outcome they were looking at is what was the NIH stroke score, to see if there was complete resolution of symptoms or an improvement in the stroke score by 4 or more points at the 24-hour period. The result was that there was no, it was a randomized control trial, blinded. The results were that there was no benefit of TPA in the 24-hour window. There was no difference in outcomes at 24 hours. And there was also an increased risk of intracranial hemorrhage associated with patients who received TPA. But on reanalysis of some of the data, they looked at it and found that there was a small benefit at 3 months, that maybe the odds ratio of 1.7 could be, they could see improvement in patients who received TPA at 3 months. This is what caused the NINDS trial part 2. 3 months. So questionable data at 3 months. no good data at 24 hours. So NINDS 2 was a comparison of favorable outcomes at 3 months using 4 assessment scales. The modified Rankin scale is the one that we most commonly think of. It was also blinded and randomized, and they looked at what they would call a favorable outcome at 3 months. So the favorable outcome was either a no or minimal disability using a modified Rankin scale of 1 to 2, where little or no disability. The odds ratio for a favorable outcome in the TPA group was significant at 1.7. They had an absolute increase of 12% of patients with minimal or no disability at 3 months. When they looked at the sub-analysis, patients who were treated in less than 90 minutes had an odd ratio of improvement at 1.7, which was significant. But in the 91 to 180 minute range, the odd ratio was 1.12 for improvement with TPA, but it wasn't significant. So the number needed to treat within that 90-minute, less than 90 minute window was 8.3. So this is really considered one of the only positive trials for TPA. And knowing that it's considered one of the positive trials, it's kind of like questionable at best, the positivity, because we're talking about the 90-minute window. Then there was another important study, because this is what looked at the extended window for TPA, the 3 to 4.5 hour window. And this was a double-blinded, but also open-label trial where we knew what the drug being used was, comparing TPA versus placebo. This was looking at the 3 to 4.5 hour window and also looking at benefit at 3 months. So the primary outcome was disability at 3 months, and a favorable outcome was a modified Rankin score of 0 to 1, or an unfavorable outcome was a modified Rankin score of 2 to 6, which is like a really wide range. There was a 7.2% absolute improvement in the treatment group. The odds ratio was 1.34, so they called it a positive study. But again, the risk of intracranial hemorrhage was significantly higher in the TPA group. It's criticized because they criticized the study because it had imbalanced groups. The primary outcome included mild disability compared to death, because the modified Rankin score of 6 is death. So how would you compare a favorable outcome to everything leading up until death? And if you went back and reanalyzed the data comparing modified Rankin scores of 1 to 2 with modified Rankin scores of only 3 to 4, there was no significant difference, which makes this kind of questionable evidence at best. There was a later trial called the IST for International Stroke Trial 3, which took all the pooled data of a bunch of the supposedly positive and negative trials for TPA, and if you can just visually look at the data and see that there really is no conferred benefit visually by these trials. The other thing that we have to look at is the NINDS exclusionary criteria, which was modified for the ECASS trial. Most importantly for us, acute myocardial infarction within 3 months was considered an exclusionary criteria. Additionally, rapidly improving or minor symptoms was an exclusionary criteria. So when we're looking at our patient who had rapidly improving symptoms, possibly an exclusionary criteria in this trial. Our Kings County and UHB policy has adopted more exclusionary criteria from the ECASS trial. So spinal or intracranial surgery, lumbar puncture. They also took the greater than 33% of infarct in the MCA territory. They moved acute myocardial infarction within the last 3 months to the relative contraindication category, as well as pregnancy and AVMs, neoplasm or aneurysm in the pinhead. They also added exclusionary criteria for the extended window. So patients over 80 shouldn't be getting TPA in the extended window, and anyone who has had anticoagulant use recently shouldn't get it in the extended window, nor anyone with an NIHSS stroke scale or a stroke scale greater than 25 should get in the extended window. Okay. The other thing that we have to remember from the NINDS trial is that their exclusion criteria were anticoagulant and heparin use within 48 hours with a PTT of greater than 1.5, a PT greater than 15, or platelets less than 100,000. And how many of you are waiting for your coags and your CBC to come back before neurology is pushing TPA on these patients? So the American Stroke Association Treatment Guidelines in 2007 even said it's become clear that the risk of hemorrhage is proportional to the degree to which the NINDS protocol is not followed, saying that when we deviate from the NINDS trial guidelines is the time that we put our patients at higher risk for intracranial So if we continue with the patient's course, if we look at this data reminder, his last known well time was at midnight when he went to bed. TPA was given at approximately 3:35 in the morning, which is in the extended window. And we know now that if we are going to treat patients within the extended window, we don't have great sufficient data to treat patients in the extended window if we follow the NINDS data. The other thing that we have to look at here is that the NIH stroke scale went from 6 to 4 in a 10-minute window. If we go back to NINDS 1, we have data that shows that TPA doesn't have any effect within the 24-hour period. So why would we attribute falsely the patient's improvement from a stroke scale of 6 to a stroke scale of 4 to the TPA? Because we already know that over large-scale studies, it doesn't work. In fact, the NINDS 1 showed us that despite not conferring any benefit at 24 hours, 7% of patients who presented with stroke will improve with placebo. ACEP guidelines in 2015 give level B recommendations to TPA given to selected patients, and then also give level B recommendations to the extended window of 3 to 4.5 hours, which basically means it's not the standard of care. Okay.
You should read the wording. The wording is the key, right? This was controversial when ACEP came out with this.
Yeah.
I think they had to go back and redo it because a lot of emergency physicians were annoyed that they had given level A evidence. But if you look, they kind of leave it open. And actually in the paper, the statement itself, they recommend you talk to your patient, which most of us do before giving this medication. Yeah. And it says like should be offered, should be considered. It's very open-ended.
May be offered and should be offered.
And I think that you guys should take that as a way to, it should empower you to, have the discussion with your patient and not just say, well, the neurology resident specialist says give TPA, so I'm going to give it.
So now I know a lot of you are probably thinking TPA is super wicked. Maybe I'm wicked for giving my patients TPA. But let's continue with our patient's course. So in the ICU here at Bellevue, they had activated a stroke code based on a reading of a repeat CTA that showed that his basilar artery thrombus had resolved, but he had a new posterior cerebellar thrombus on the right. It looks like he just embolized a little bit further, and he had a small cerebellar stroke area that showed up on the repeat scan. They decided that the patient's left-sided numbness and ataxia didn't correlate with a cerebellar stroke, so they didn't actually do any further intubation. They canceled their stroke code. They started a statin, a beta blocker, and an ACE inhibitor, and then they repeated his COVID test and it was negative. The second time. On hospital day 1, they did troponin I on these ones, so it was trended 9.3, 9.3, 8.9, not really a significant decrease. They did an official echo, which had no new findings, and the bubble test that they did showed no ASD, VSD, and COVID test number 3 was also negative. Hospital day 2, he had a cardiac cath, which showed a complete LAD occlusion with no intervention at that time. Basically, they were thinking it was a late presentation of MI with possibly a complete transmural infarction given the Q8 on the EKG. So they wanted to do a MRI to see myocardial perfusion and viability of the tissue before they decided to do any interventions. Now that they're 24 hours past the TPA, they were giving clopidogrel and aspirin started, and the patient was transferred to the CCU. On hospital day 3, he had an MRI of the heart, which showed a left ventricle apical thrombus, extensive infarction of the LAD territory with non-salvageable tissue, and a clinically insignificant VSD. So no reperfusion interventions were attempted. They didn't want to stent or do anything because they thought it was a complete infarction, and they downgraded the patient to medicine. Now I know what you're thinking. Wait a minute, left apical thrombus. Didn't you tell me before that left apical thrombus is a risk factor for giving people TPA because you risk mobilizing the thrombus off the wall of the heart and sending it to the brain? Yes. So the AHA and ASA actually have guidelines for this, where they say that patients with an ischemic stroke with known thrombus can be given TPA. They call it a reasonable class 2B, but if you look at what class 2B actually means, it's like, maybe. So it's really based on expert opinion. They also look at patients with moderate ischemic stroke with known thrombus, treatment with TPAs, Ebbett level of C on that one. Okay. So it's complicated, and there's a lot of people who look at the data in different ways. Neurology looks at the data one way, we look at the data another way. So we pooled our faculty, and we gave them this scenario. 45-year-old man presents to the ED with difficulty speaking and left-sided numbness that began 1.5 hours ago. You confirm that he was hospitalized for an MI 8 days prior, but he refused cardiac cath. He has no chest pain or dyspnea, takes aspirin and lisinopril. The vital signs and point of care glucose are normal. There's disconjugate left AC deviation and severe dysarthria. You activate stroke code, and the CT shows a large vessel occlusion. The patient is within the 3-hour window, and there is no absolute TPA contraindication. Neurology consult recommends giving TPA. Would you give it? These are our results. So 20 respondents, 13 said yes, 6 said no, and 1 person said they would activate neurointerventional radiology for EVT without TPA. So now you're probably thinking, well, is there some way to treat both of these presentations at the same time, whether one happened first or one happened second? How do we treat patients who present in this situation? So the AHA made a statement on acute cardiocerebral infarction saying that if they have an MI in the preceding 3 months, there's class 2A level of evidence for treating the patient with the dose appropriate for cerebral ischemia. So that TPA dose of 0.09 milligrams per kilogram given with a 10% bolus. Is there a unifying dose for acute coronary cerebral infarction? It's hard to say. When you look at the dose for acute myocardial infarction versus the dose for acute ischemic stroke, you take a 70 kilogram patient, you get a 100 milligram dose of TPA for the heart, and you get a 6.3 milligram dose of TPA for the brain. It's a 15 times difference in the amount of TPA you might be giving to this patient. In 2016, the American Stroke Association gave this rationale saying that it's feasible to give the stroke dose of TPA, then to proceed to stenting if indicated for the acute coronary event, because pretreatment with TPA for the stroke does not decrease the efficacy of the benefit for PCI. Okay? But here's a potential pathway for how we should look at patients when they come in who may be presenting with this dual diagnosis. First, if you've got someone with stroke onset within 4.5 hours, less than 4.5 hours, and onset of myocardial infarction, I'll say debatable 4.5 hours, and myocardial infarction onset within less than 12 hours, you get your CT head, CTA, perfusion studies, whatever you want to do, plus EKG. Then, if you decide if the patient is hemodynamically unstable. If the patient is hemodynamically unstable, cardiogenic shock, then you would proceed immediately to PCI. But if they are stable, you can give them the TPA at the stroke dose. Then you look at the studies and you see, do they have large vessel occlusion or perfusion mismatch? If they do, then you say, okay, you can send them to EVT for stroke. And if not, then you can send them for medical management and admit them. Likely to telebeds, also consider that. Then you look and see, do they have a right MCA infarct? And if they do, tele for close observation. If not, or if they have previously, if they haven't had a PCI, you can send them for PCI at this point, or PCI after they've been evaluated by cardiology. So basically, the theory is, if all else is equal, treat the first thing first, or the thing that's going to kill the patient first. But otherwise, here is a combined pathway where you can look at treating the patient. Our patient had a 10-day follow-up that showed they did their MR to see if the heart tissue was viable, or they scheduled a repeat MR to see if there was continued improvement in the viability of the tissue, to see if his ejection fraction would be improving. He noted that he's now walking with a cane due to some of the ataxia from the deficit that he probably had from the cerebellar stroke that they saw on the second CT. He had the paresthesias were still there but improving, and overall he felt better with no signs of heart failure like chest pain, shortness of breath, or swelling, and he has had no further hospitalization since that hospitalization. Just want to say, wow, that was quite a journey with a lot of evidence and a lot of information. But we can summarize by saying that patients with stroke can have heart attacks and vice versa. We need to be really diligent about controlling what happens during the stroke codes when we call a stroke code and invite neurology to the emergency room to start treating patients with us. Anchoring bias has to be avoided, because if we focus too heavily on one diagnosis, and also if we focus really heavily on the evaluation of the neurologist doing their neuroexamination, they're only going to focus on neuro-related complications like vertigo or other things like that. They're not going to be looking for those other things like abdominal ischemia or simultaneous cardiac myocardial infarctions that we would be looking for, because that's what we're trained to do. We also have to understand the risks and the benefits of the treatments that we're giving to patients. And just because neurology and neurologists want to interpret the trials as safe, it doesn't necessarily mean that it's safe for our patients based on the data that we know. We also have to evaluate all our patients for absolute and relative contraindications before we start giving the treatments to them. And my final point is TPA more like or TPA more like TPI. Okay? So now, please go out there and be great, powerful auditors.
Do you think this patient had a stroke scale of 6 when they gave the TPA? Or did they give it a stroke scale of 6 because that's the score that they need in order to give the TPA?
That's what
He had a stroke scale.
And this is a plug that everybody should do their own freaking stroke scale if you're going to give the patient TPA.
I don't know how they got to 6.
So
With the data that we
there's
have.
a really great app you can download called Neuro Toolkit. It's a couple of bucks, and it allows you to just have the bedside view stroke scale, so you yourself can get it before neurology gets it. So you can get it before neurology gets it, and that way you can compare it and see if they're manipulating the data. Because as I looked through the patient's chart, they actually had stroke scales that varied up and down throughout the course of the TPA as the infusion was going on. So at one point they documented it as 4, and then it was 2, then it went back to 4, and then it went back down to 2. And when they sent the patient to NICU, it was 1. But it's all kind of BS anyway, if I channel Dr. D'Souza for a minute. It's all kind of BS because we know that by NINDS 1, TPA shouldn't have any effect in the first 24 hours. It's really the only first benefit is a 48-hour window. So, all right, sorry, the 3-month window, 3-month window, not window, 3-month window. Any other questions?
That's great.